Okay, well, good morning, everybody. My name is Madeleine Pfleger. I'm one of the fellows, and today we're going to have an interesting case presentation of a 52-year-old male who came to the clinic with a primary complaint of painful wound on the right lower leg that was present for more than a year. He reported that the wound initially began as a scratch that failed to heal and progressively enlarged over time. Patient was receiving nightly wound care, and he was following at a wound care clinic. He reported consistent use of medical grade compression garments over the past 2 months. Accompanied to this, he also reported symptoms that included heaviness, aching, fatigue that were more severe on the right compared to the left. In his medical history, we included patient had kidney stones and scoliosis. He reported no significant family history. He was a former smoker. He also reported a history of back surgery and denied any arterial or vein interventions. He also denied any history of venous thromboembolism, no allergies to any medication, and he reported that sometimes present lower back pain and joint pain. On the physical exam, patient was normotensive, overweight. He had peripheral pulses present bilaterally. The lower left extremity was classified as SIP0 with no stigmata of venous insufficiency, and the right lower extremity was classified as SIP6, characterized by an active medial distal calf ulcer with a large clean wound with groove granulation tissue and peri-wound skin changes consistent with healing. The wound with clear fluid without odor or purulence. I don't have the exact measurements, but we can appreciate that longitudinally was for sure more than 10 centimeters, times around 8 centimeters. The circumference measurements were same bilaterally, but the BCSS were 16 compared to 2 on the right side compared to 2 on the left. On duplex exam, it reported no DVT, but as we can appreciate, there was bilateral reflux on GSV and reflux of the right perforator distal calf. The diagnosis was chronic venous hypertension on the right lower extremity with complications like active ulcer, restless leg syndrome, and disorder of pigmentation. On the assessment plan, we developed a treatment plan for treatment of superficial and perforator vein, also evaluation of the pelvic vein arterial system, continue with the compression stocking, continue with the wound care, and regular leg elevation. And this brings us to our topic of today, that is perforator vein incompetence. As we all know, the perforator veins connect the superficial with the deep vein. They obliquely perforate the deep fascia, that's where the name comes from, and they play an important role in equilibrating the blood flow during calf muscle contraction. The majority of perforators have a one subfascial bicuspid unidirectional valve. Exception is on the foot that is bidirectional. And this allows the blood flow to go from the superficial system to the deep system. This prevents the backward flow or the regurgitation, as we can appreciate on this picture, during muscle contraction. It has been reported that since 1960s that we have around 115 perforator veins in each lower extremity. The distribution, it varies, but it's around 60, 50s in thigh and leg, 8 in the popliteal fossa, and 20s, 28 on the foot. Of these 150 perforators, approximately 30 perforators, so 20 something percent, has been commonly identified as incompetent, playing a role in venous pathology. But how can we name it or classify it? Well, currently the perforator veins are named according to location. So we have thigh, knee, leg, and ankle perforators. And later we subdivided these on anterior, posterior, medial, and lateral. So if we need to name a perforator, we can say it's in the medial, it's a medial leg perforator or an anterior thigh perforator. And this systemic approach eliminates the confusing historical eponyms like Hunterian, Dodd, Boyd, or Coquette that we all are familiar with, and provides a clear and precise anatomical reference for the clinical practice. As we can appreciate here, we all have from medical school and studying for all our tests different mnemonics. And in this case, for Hunterian, Dot, Boyd, and Coquettes, the mnemonic was high density basal cells, a way to remember. But now all this name has changed, and we have mid-thigh or distal thigh perforator for the femoral canal perforators, for the Boyd's perforator, and now the paratibial perforator. And one of the most clinically relevant, the Coquette's perforator, and now the posterior tibial perforator. We have this paper from 2011 that also describes the flow and the diameter thresholds of perforator veins. On the flow, we have that the outward flow from perforator to superficial is typically below 350 milliseconds. So anything above that is considered a reflux. However, many centers like us use a more conservative threshold of above zero point 0.5 seconds to define the reflux of the perforator, since this cutoff aligns with the rest of the venous segments. Regarding the diameter, the normal diameter of a perforator vein is below 3 millimeters. Anything above 3.5 millimeters, according to different studies, suggests that most likely shows reflux above 3.5 millimeters. But it's important to know that where larger the diameter strongly indicate reflux, there's an exception around 1/3 of the refluxing perforators can be smaller than this cutoff. In this paper, they reported different factors or characteristics of the perforator veins. So first, we have that the perforator veins are often wider below the fascia, where the luminal expansion is less restricted. So if there's a perforator with a diameter at the level of the fascia above 3.5 millimeters, it's highly suggestive of incompetence and implies weakness and level of destruction of the fascia level. They also reported that incompetent perforator veins are characterized by significant elevated mean and peak flow velocities, increased volume flow, and a greater venous volume outward displacement. Very important to know is that the perforator vein reflux rarely will occur in isolation. It has been reported and documented that it is primarily observed in continuity with the superficial vein reflux. So the reflux is developed first in an ascending manner from superficial vein toward the perforator veins, and later in a descending manner and re-entry points of the perforator veins. This hypertension dilates the vein and promotes its incompetence. Concurrently, the deep vein competence can further impair reflux in perforator veins, which will exacerbate the hemodynamic. But the most significant outward flow in perforator veins is seen in cases of a triple system incompetence. So these will include the superficial, the perforator, and the deep vein reflux. This severe form is more prevalent in patients with chronic venous disease that is more advanced, so with skin changes. Now we have this paper from 1999 of Dr. Labropoulos. They wanted to compare and analyze the characteristics of perforator of the lower extremities. So they had two groups, the healthy volunteer groups and the patient groups. So healthy was 30 limbs for analysis, and the patients were around 103 limbs for the study. They found a 581 perforator veins in the group of patients. So no perforator vein was found in the healthy group. Out of these 581, 28% were found to be incompetent. And the total number of the perforator veins and incompetence one was significantly increased with the severity of the chronic venous disease. So the more the severe, more perforator veins were found. They also showed us the other study that the incompetence perforator veins were consistently larger than the competent ones with a subfascial diameter greater than 3.9 millimeters. The main location of perforator in this study was on the mid-calf area, and it reported that smaller were located on the knee and the ankle and lower thigh compared to the mid-calf and the rest of the calf and mid-thigh. Also, it is important to know, and it was reported here, that the perforator vein incompetence was most frequently associated with a superficial vein reflux. The 74% of the perforator were associated with superficial. 21% was associated with superficial and deep vein reflux, and only 5% were associated with deep vein reflux alone, which underscores the role of superficial vein pathology. This paper from 2000 is very interesting. They analyzed the relationship between the number, competence, and diameter of veins on different clinical status of the chronic venous disease. So they have a total of 311 limbs, and these 300 were distributed on different SIP classes. So SIP 01 were 50 limbs, 2 and 3 were not 95, SIP 4, 58 limbs, and SIP 5, 6 had the highest of 108 limbs. This comprehensive approach enabled a thorough examination of how perforator vein abnormalities correlate with the escalating severity of chronic venous insufficiency. And the findings were the following. The more advanced or the more severity of the chronic venous insufficiency, more perforator veins first were shown, and second, more incompetent perforator veins. So SIP-01 demonstrated 88% of perforator veins, but only 6% were incompetent. And we can see how this exponentially increased as the SIP grades increase. So from 6%, now 2 and 3 is 52% incompetence. And when we get to the SIP 5 and 6, 90% show incompetence. We can also appreciate how the diameter of the perforator vein increased from 2 millimeters to 4 millimeters. And these findings highlight that as the CVI progresses, there is a pronounced increase in both the presence and the pathological enlargement of medial calf perforator veins. But how all this leads us to a venous ulcer? Well, first, when the perforator valves become incompetent, the blood flow goes backwards from a high pressure in the deep vein system into the superficial vein. The incompetent perforators will act as a direct conduit that transmits this elevated deep venous hypertension to the superficial venous system and surrounding subcutaneous tissues. The refluxing perforators effectively short-circuit the calf muscle pump, and the blood is ejected from the deep venous during muscle contraction, immediately flows back through incompetent perforators, preventing an effective venous emptying. This results in a sustained venous hypertension even during ambulation, which is the most critical part, is even during ambulation. The chronic damage is with the chronic venous hypertension. This causes a capillary dilation and increases permeability, leading to the leakage of plasma proteins and red blood cells into the interstitium. This results in a fibrin cuff formation around the capillaries and trapping and activation of leukocytes, severely impairing oxygen and nutrient diffusion to the skin. This persistent inflammatory state, coupled with impaired nutrient supply, will lead to lipodermatosclerosis, skin fibrosis, and induration, reducing tissue resilience and significantly impairs the wound healing, making the skin fragile and highly vulnerable to even minor trauma, like the case of our patient. Once the skin breakdowns occurs, the elevated venous pressure actively prevents a normal wound healing, and this ongoing reflux from incompetent perforators continues to damage the surrounding tissue, leading to a chronic and recurrent ulcers. So incompetent perforators near the ulcer base are strongly associated with non-healing or recurrent venous ulcers. Now, very important to know that these pathology from perforator veins do not usually cause an ulcer in isolation. They become pathogenic when combined with superficial and or deep venous insufficiency. But they play a critical role in maintaining this venous hypertension at the ulcer site. And this explains why targeted treatment of incompetent perforators, especially those that are adjacent to the ulcers, can significantly improve healing. And now talking about public health, this is extremely important because venous leg ulcers represent a significant and ongoing clinical challenge due to their high prevalence, slow healing rates, and frequent recurrence, highlighting the need for an effective treatment strategy. It has been documented that around 60 to 80% of all leg ulcerations are venous leg ulcers. Unfortunately, only 40% of them are expected to heal within 3 months, which indicates a slow and often incomplete short-term resolution. Sadly, 70% of them will reemerge within the 3 months, which shows how the chronic nature of the condition. So it's a high recurrence rate and a low healing rate. This is why in 2010, a group of experts in the Sixth Pacific Vascular Symposium aimed to decrease the venous ulcer prevalence by 50% over the next 10 years. They highlighted initiatives like better diagnosis, prevention, and management. Unfortunately, in the 2023 venous ulcer platform study, it was reported that this goal has not been met yet. And this brings us to the management of venous leg ulcers. So the Society for Vascular Surgery and the American Venous Forum in 2014 developed a clinical practice guidelines for their management. And we're going to have first different scenarios. The first one would be a patient with an active ulcer that has a combined superficial and perforator venous reflux with or without deep venous reflux. In this case, they suggested ablation of both the incompetent superficial veins and the perforator veins, in addition to the compressive therapy. This brings us to this study in 2012 called The Impact of Ablation of Incompetent Superficial and Perforator Veins on Ulcer Healing Rates. This study was was very specific study, and you're gonna see why. First, the objective was to precisely measure the change in ulcer healing rates following the ablation of incompetent superficial and perforator. And the group of patients had to have an inclusion requirement that the ulcer was not responsive to a compression therapy alone. They were evaluated through different clinical and duplex ultrasound assessments. And what they did is that patients that were not responding in a period of 5 weeks to compression therapy with multilayer dressings and also proper wound care were later passed to the next stage, that would be vein ablation. Now, the requirements that they used for the superficial was reflux above 1 second and diameter above 3 millimeters. And what they did is that every 4 weeks, patients were evaluated. If the ulcer was not healing, they were getting the next treatment. And every 4 weeks, if the ulcer was not healing, was the next one. It could be a superficial, like a GSV, and if the next one could be the perforator, that will vary according to the treatment plan of the patient. So the great thing about this study is that they did a very specific following quantifiable tracking. The ulcers were photographed weekly with a ruler in a software called Wound Expert, and they calculated the ulcer area. Healing rates were determined by plotting the area changes over time, offering a precise and objective measure. As we can appreciate here, the results of this study is that first, it was 110 chronic venous ulcers and 88 limbs. 74 got superficial treatment and 66 got perforator treatment with radiofrequency ablation. The ulcers were persisted for 71 months with a mean area of 23 centimeters squared. And the results were that the ulcer healing rate significantly improved from 1 centimeter squared per month to 4.4 centimeters squared per form after ablation. Also, the healing rates varied according to the last vein ablated. So if the last vein ablated was the GSV, the mean improvement was 6.4, for SSV 4.8, and for perforator vein 2.9 centimeters squared per month. At the end, it shows that 76% of patients achieved complete healing within a mean of 142 days during the 12-month follow-up period. And the conclusion was that these findings demonstrated that targeted ablation of incompetent superficial and perforator veins leads to a measurable and significant reduction in ulcer size and ultimate healing for patients that were previously unresponsive to the conventional compression therapy. Another story about superficial and perforator vein is the systematic review from 2023. They analyzed 7 studies that involve 172 limbs, and they evaluate the effect of combined treatment of superficial venous reflux And incompetent perforator vein, that was one group. And the second, versus superficial venous intervention alone. So one group was treated with superficial and perforator vein, and the other group was only superficial. Analyze all the data and all the studies comparing concomitant um, superficial perforator outcomes with standard therapy. The variables were ulcer healing, time to healing, recurrence, disease severity, quality of life. And the results among different studies, the main ones was first, there was a concomitant, the group of concomitant superficial and perforator show a significantly reducing ulcer recurrence from almost 18% to 4%, with a strong benefits for patients C5 and C6. Second, the number of perforator veins remaining at the follow-up significantly decreased in the concomitant group. Now, for ulcer healing, it shows 92% against 78 on the group with concomitant. The ulcer healing was 92%. However, this showed to be not clinically significant because the power was above 0.05. And in both groups, there was comparable complication rates. So there was no difference on safety on both groups. This shows that while concomitant treatment show clear benefits in reducing recurrence and the residual incompetent perforator veins, its direct impact on the initial ulcer healing and overall disease severity was not statistically significant across all these studies. Now, following with the guidelines, we have a second scenario of a patient with a C4B or C5 that has a combination of superficial and perforator veins, with or without deep venous disease. In this scenario, they suggest ablation of the incompetent superficial veins to prevent the development of a recurrent venous leg ulcer. Now, the treatment for the incompetent perforator veins can be performed simultaneously with correction of the axial, or it can be staged. The third scenario was a patient with a healed or active venous ulcer that shows a pathologic perforator venous reflux in the absence of a superficial venous disease. And in this scenario, they suggest ablation of the pathologic perforator vein in addition to compression therapy. Now, the last guideline explains about the treatment options. So for treatment alternative, we have that patients would benefit from perforator ablation, and they recommend percutaneous techniques that includes ultrasound-guided sclerotherapy or endovenous thermal ablation over open venous perforator surgery to eliminate the need for incisions and areas of compromised skin. This brings us to the story in 2016 of the current state of treatment for perforator veins. Now, before talking about the treatment, we need to know that the treatment for perforator veins has been happening for almost a century. In 1938, Dr. Lytton developed his well-recognized Lytton procedures that was performed until 1990s. It was an open surgical technique from with an incision from the knee until the medial malleolus. They dissect at the level of the subfascial. They visualize the perforator veins, and these were caught uninterrupted. However, this technique it involves a high morbidity. Patient has to spend a long recovery time. There was a high increase of infections. So on 1990s, another technique was developed that is the subfascial endoscopic perforator surgery. We're going to speak about in a little bit. And this technique was around 1990s to in 2000s. At the end of 2000s, more minimally invasive techniques were developed. That are the ones that we use as of now. We have laser, endovenous laser ablation, radiofrequency ablation with stylets, and sclerotherapy. Now, for the subfascial endoscopic perforator surgery, this was, compared to the open perforator, was minimally invasive. What they did was on their spinal or even general anesthesia, they performed incisions at the level of the skin above the ulcer introduced endoscope that reached the subfacial level, and with CO2, the area was insufflated. Before this, the limb was exsanguinated. So with the CO2 insufflation, this allows a proper visualization of the perforator veins. And once visualized, the vein was clipped, and with scissors, it was interrupted. This technique showed improvement in morbidity compared to the open surgical technique. However, it also requires a more recovery time. It requires anesthesia. So, in compared with the techniques nowadays, is outdated. This is more a schematic way. As we can see here, the endoscope reached the area, clips on both sides, and endoscopic scissors interrupted the perforator vein. Also, the main thing about this technique is that these patients already have skin damage. So the incisions with the insufflator of the CO2 it requires more damage to the tissue on the patient. We have this paper from 1999 in which they describe results of this technique for the treatment of chronic venous insufficiency. They study 146 patients and perform 148 SEPS procedures. Out of these patients, 83% of these were class 5 or class 6. But it's important to note that 71% of these patients already had a superficial vein procedure before. The outcome shows no deaths of pulmonary embolism, but one patient developed one DVT. The results of this study show 88% of cumulative ulcer healing rates at 1 year, with a median healing time of 54 days. The patients experienced a notable improvement in their clinical scores, dropped from 9 to 4. And the main thing is that despite initial success, there was an ulcer recurrence, so it remained a concern. At 1 year, 16% of patients reported a new development of an ulcer, and at 2 years, this increased to 28%. And this was particular in patients that had post-thrombotic limbs. So the study highlighted that outcomes were less favorable in patients with a history of deep venous thrombosis or occlusion. At the end of this paper, there was a discussion of different providers showing concerns about inconsistent preoperative evaluation, incomplete venous imaging, and variability in the procedures. And this is for this technique. Now, going on the next technique, we have radiofrequency ablation, which we all know it, but I'm just going to go really quick, is performed with a stiff RF catheter that has a distal heating device mounted on a stylet that directly punctures the perforator vein. The catheter is advanced until it's adjacent to the deep veins and is surrounded by a tumescent solution. Then the catheter is activated and the vein is treated for 30 or 60 seconds, depending on different papers have 30 to 1 minute of each cycle, and each cycle should be on 4 quadrants of the perforator vein. The ablation process is repeated along the length of the perforator to accomplish a effective closure. This brings us to this paper, very important paper from 2011 of Dr. Lawrence, that they describe endovenous ablation of perforator veins that is effective treatment for recalcitrant venous ulcers. In this paper, they evaluated 45 patients with a total of 75 ulcers. So all the patients were classified of CYP6 that were refractory to standard care. So patients underwent more than 3 months of optimal wound care, compression, and correction of superficial venous reflux and arterial issues, and ulcers were not improving. What they perform is radiofrequency ablation on these perforators, and after the procedure, the perforator closure was verified with an independent duplex ultrasound. The closure rate was 71% after repeat procedures of radiofrequency ablation. Ulcer healing was 90% in the group that the perforator veins were successfully treated. The critical finding here is that no ulcer heal without a successful perforator closure. So if the perforator didn't have a successful treatment, the ulcer was not healing. The safety of this procedure showed that there was no complication reported. Now, from this study, we can see that ulceration results from venous hypertension that often involves perforator that resist conventional treatment. The incompetent perforator sustains hypertension, preventing the ulcer healing even after other reflux sources are addressed. And also show that endovenous ablation is safe and it could be minimally invasive alternative to surgery for complex cases. The study concluded that endovenous ablation is feasible, safe, and effective for the treatment of venous ulcer. The successful closure over 90% of ulcer healing rates with minimal recurrence, and perforator ablation should be considered as a vital intervention for chronic non-healing ulcers once other venous reflux causes are managed. This paper, I just want to go really quick, it's from 2017. They tried to make some modifications on the technique to see if the time could be shorter. So as we know, for radio frequency has to be a temperature of 85 degrees Celsius and impedance lower than 400. So in this study, they had a total of 642 perforator veins, and they divided these in three groups. The first group received a temperature of 85 with each cycle of 90 seconds, which gives us a total of 6 minutes. The second group, it was a temperature of 90 Celsius with each cycle 60 seconds and a total of 4 minutes for the four quadrants. And the third group, it was 95 Celsius with 45 seconds per cycle, and it was a total of 3 minutes for the four quadrants. The results, first, there was not a clinical significance. They always say on the 60% successful closure, but this was not significant because the power was above 0.05. So this study showed that shortening the protocol time and increasing the target temperature for radio frequency ablation did not make any difference on the early success rate of ablation. Going on the next technique, we have this comparative study of radiofrequency ablation with cyanoacrylate. It was a retrospective study that they compare treatment of perforator veins with these two techniques. A total of 180 patients that were C5 and C6. 55 received cyanoacrylate and 63 received radiofrequency. At 12 months, the radiofrequency group showed a superior closure rate of almost 89% compared to the 73% of the cyanoacrylate with a good power. And also shows that patients on the radiofrequency ablation experience a greater improvement in quality of life. So the CVIC-20 for radiofrequency decreased from 19, but increase on 19 on the patient with radiofrequency ablation versus 15 on the patients with cyanoacrylate. Now, regarding ulcer healing, both treatments demonstrated similar effectiveness, 85 to 80%. The difference was one patient because the sample is small, so there was no significant difference on ulcer healing rate. And both procedures exhibited low and comparable complication rates. The study concluded that while both are safe and effective, RF offers a more durable anatomic success and better patient-reported outcomes. This study from 2024 used also cyanoacrylate, so I just wanted to bring it here because it's not something that we use on a usual basis, but I wanted to bring a little bit of the technique. The study evaluated the relationship of perforator veins and healing ulcers on patients that underwent cyanoacrylate after compression and wound care didn't improve the ulcer healing for 3 months. It was a retrospective study, and at 12 months, they evaluated the perforator vein closure and also diameter reduction and VCSS. The technique that they used in here was with a 21 gauge needle. that was inserted at the midpoint of the perforated veins. They utilized a pre-filled 2cc syringe with zero point 0.5 ml of cyanoacrylate. Once they punctured, the adhesive was swiftly injected 1 centimeter away from the deep veins, and its deployment was immediately confirmed by ultrasound, followed by 10 seconds of manual compression on the injection site. This process was repeated on different perforator veins, and patients' limbs were wrapped in the usual elastic bandage that they have to keep for 24 hours. And they also were placed on prophylactic antibiotics, but no prophylactic anticoagulation. The results were 87% of patients achieved complete ulcer healing and closure of the perforator veins at 12 months. There was a significant ulcer reduction. The preoperative ulcer diameter decreased from 7 to 0.28 centimeters square. Also, the BCS score improved from 18 to 8, and there was no cases of postoperative paresthesia or deep venous thrombosis. Now, in this study, they reported predictive factors. So they reported that if a preoperative ulcer diameter was above 11 centimeters square, this predicted for a non-occlusion almost on 100% accuracy. The second is that each 1 millimeter increase in the diameter of the perforator vein increase a non-occlusion likelihood by 9 times. And in this study, they reported that the presence of diabetes increased a non-occlusion risk by 3.4 times. So the conclusion was that cyanoacrylate occlusion of incompetent perforator veins is a highly effective and safe treatment option, leading to a significant ulcer healing and clinical improvement of CIP6 patients with specific factors that were predicting long-term success. Going on the next technique, we have endovenous laser ablation. A little bit about the technique. It could be with different wavelengths, but the one that has been used the most is the 1470 nanometers that we use also. This one is introduced into the perforator with a 21 gauge or 16 gauge needle. The energy is delivered at 50 joules per 5 millimeters through the fiber tip, which ensures the treatment along the entire length of the incompetent perforator vein. This brings us to this study from Dr. Gibson and Dr. Elias. This was a prospective study that evaluated the safety and effectiveness of laser ablation with a 400 nanometer optical fiber on the treatment of perforator veins. The sample was 83 patients that were distributed on C4B, C5, and C6 disease. In this study, the laser was positioned at the near fascia and 1 centimeter from the deep vein. The usual generator was 5 to 7 watts for 10 to 15 seconds, so 50 to 70 joule to each level. This was applied at 2 or 3 perforator levels around the fascia, and the results showed that at 10 days post-procedure, the closure rate was 77%, which maintained almost similar results, just mildly decreased to 71% at 12 months, which is still a great closure rate. At the beginning of the study, 23% of the patients had active ulcers, and by 12 months, this decreased to 11%. So almost half of the, practically half of the ulcers healed by 12 months of the study. Minimal adverse events were noted, like 1 tibial DVT and 1 patient with persistent pain. So this study showed that the endovenous laser ablation for perforator veins is safe, effective, and improves quality of life with no major device-related adverse events. Now we have this interesting study of laser ablation. They compare this treatment on 3 groups. Basically, they had a group of 1 patient of gray saphenous vein alone. The second group was patients that the gray saphenous vein alone was treated, but patients had incompetent perforated veins. Sorry, I was about to sneeze. And the third group was patients that underwent ablation of GSV and perforated veins. So what these studies show is that the combination of treatment on the GSV and the IPV groups achieve a significantly higher ulcer healing rate of 71% compared to the 33% of the second group. They also show that there was no significant difference in time to ulcer healing or postoperative complications or ulcer recurrence. Now, I just want to make a exception here. The no differentiation of the recurrence on the groups is because the power was above 0.05. But the group that they both were treated showed 0% of recurrence compared to the group that only the GSB was treated, that it was 11%. Also, it's important to know that there's a big difference on the sample size on these two groups. The study showed that for active venous cestasis ulcers, a comprehensive assessment for both superficial and perforated venous reflux is crucial, guiding a combined ablation when both are present. Because the key here is that the incompetent perforated veins were present, but they were not treated. And when they were treated, showed significant improvement. Now, the next modality, we have ultrasound-guided phone sclerotherapy. It's usually polidocanol or STS, injected under ultrasound guidance to close the perforating and surrounding varicosities. The good thing about this treatment, as we all know, is that it's low cost, easy to use, a good patient tolerance, and accessible treatment modality with a small risk like injection at the site ulceration. It could be DVT. The big thing is accidental arterial injection. That one is important. And we have this study from 2021 that showed how treatment of sclerotherapy of insufficient perforated veins in patients with severe chronic disease. So they trying to determine the anatomical success and clinical response to USG for treatment of patients from C4 to C6 and identify the factors that were associated with the outcomes. It was a retrospective study of 73 limbs. They were evaluated at 1 and 12 months with clinical and Doppler ultrasound evaluation. The majority of the patients were C4, 80%. Only 12% had an active ulcer. Important to know that 30 limbs in this group already had a previous GSB procedure, and the usual diameter was from 3 to 7 millimeters on the perforators. The results, first, we have that 82% used polidocanol because until a certain point, STS was used, and from there on, it was only polidocanol. So it was more polidocanol than STS. Patients also underwent treatment for axial thermal ablation and sclerotherapy. Complications were a small, around 4% of asymptomatic DVT. It shows that there was a high occlusion rate of 97% at 1 month, and this mirrored with an early clinical improvement of 97% of patients. So the occlusion rate and the clinical improvement were very similar at 1 month post treatment. But at 12 months, the occlusion rate decreased to 58%. And patients require also a secondary treatment. The clinical improvement also decreased to 77%. But the important thing is that 7 out of 9 patients experienced ulcer healing with a median of 4 months. The study identified that the diameter of the perforated vein, because as we saw before, it was around 7 millimeters, 3 to 7, acted as a sole factor that was significantly associated with a 12-month Doppler ultrasound occlusion rate. Also showed that it was effective for the treatment of perforated veins from C4 to C6. This second study of sclerotherapy wanted to evaluate the factors that influence the perforated thrombosis and predict healing with perforated sclerotherapy for venous ulceration on patients that didn't have any axial reflux. So all patients were class 6, and they were evaluated with duplex ultrasound. They receive first, before starting the procedure, they receive compression and wound care, and also saphenous vein reflux was treated with endovenous ablation. So only the patients that were not improving after all these measures were taken were included in the study. The sclerosa was injected in the varicosities that were feeding the perforated veins and distributed with local massage. And after this, the pressure was held for 2 minutes with ultrasound probe. The follow-ups were every 2 weeks to assess the thrombosis and any risk for DVT, and also to evaluate the ulcer size on each visit. The key outcomes included first, incidence of thrombosis, second, a complete occlusure, and healing ulcer healing status. And the second outcome was the recurrence after initial healing. The results show that from the 73 ulcers, first, 36% had history of DVT and 30% had history of deep venous reflux. And of the total of patients that were treated, 59% showed an ulcer healing rate with a mean of 30 months. And the thrombosis of the perforated rate was significantly higher, with showing 69% of healed ulcers were by the end of the study. In the study, they reported that complete thrombosis of perforated veins in an ulcerated limb was the sole positive predictor factor for ulcer healing. And conversely, a large initial ulcer area was negatively impacting the healing. The negative factors on this study that they described was the male gender, obesity, and warfarin. But it's important to note that the male gender were also the most obese patients, so there's also a confounding here. They reported that factors like hypertension and increased follow-up correlate with a high ulcer recurrence rate, while an increased age correlated with fewer recurrences. In this study, the USD demonstrated a strong and significant record with low incidence complications. Only 3% showed thrombosis of calf veins, and they were asymptomatic and easy to manage, which made the USD a viable option. Now that we see all the therapeutic options, we have this study from 2016 that they evaluated or the comparison of different techniques for treatment of perforated veins. So the objective was to compare early closure rates of the perforated veins after different modalities, and also to evaluate possible risk factors for treatment failure. These are the techniques that they use, very similar to what I explained before. In post-procedure, all patients received daily compression therapy and underwent ultrasound examination at 2 weeks to evaluate for closure rates. The results first, it was 112 patients with a total of 296 perforated veins. They were distributed kind of equally on the modalities. 31% received radiofrequency ablation. The one that they used the most was USG 48%, as we know is lower cost. And endovenous laser ablation was 21%. Of the total of patients, 67% had C5 and C6 venous disease, and the mean perforator size was 4.7 millimeters. They evaluated different factors, and they found no significant difference on age, BMI, diuretic use, anticoagulation, or diabetes. And the results show that radiofrequency ablation had the highest closure rate with 73%, followed by laser ablation with 61%, and USG with 57%. And this study, they reported that the patients that were failed of USG, so the patients that the USG didn't accomplish the closure rate, some of them receive a second treatment with a thermal ablation, whether laser or radiofrequency, and this improves the closure rate to 85 or to 89%. They also reported that the only predictive factor that impacted negatively the closure rate was a BMI above 50. And in this case, they reported that the closure rate decreased to 37% in this group of patients. Regarding complication rates, It was low with a 5% of patients having episodes of DVT, but it was mainly tibial veins and asymptomatic that were easy to manage. The conclusion of the study was the radiofrequency ablation was the most reliable method for perforator closure and significantly outperformed USG. However, they stated that, or recommended, that since USG is easy to tolerate for patients, lower cost, and less invasive compared to others, they stated that a good way is doing USG for patients, and the patients that didn't improve, in that case, do a thermal ablation because you still have 57% of patients that will improve and may not need a higher, more or elaborated procedure. That was their conclusion. Now, for our patient, returning to our clinical case, he underwent radiofrequency ablation of the GSB and received varithena on the right perforator distal calf. And the important thing in this case is knowing our insurance guidelines because this patient had anthem. And for anthem, it reported that it needs to be our USG or varithena. So that's what the patient received, varithena. As we can appreciate here, different guidelines of insurance. Majority accepts thermal modalities, and for sure, they all require that it has to be C5 or C6 in order to be treated. Some of them also report that the patient cannot have a superficial reflux. Now, finishing with therapeutic options, it's important to know the technical challenges for perforator vein.
Yeah, Madeline, start to wrap it up, hon. All right, we're getting close to the end.
Yes, I'm also getting close to it. Absolutely. So technical challenges is lower closure rates compared to superficial treatment, which needs repeated treatment later on. The negative predictive factors are anticoagulation, obesity, and only 80% of these perforators will remain closed. The second thing is that difficult cannulation that is after a challenging location, morphology, they tend to be more deep, tortuous, and located damaged and ulcerated skin. We also have the washout of foam that is important to know once we preserve this procedure. And there's also a new vein formation that we don't know on the follow-up if there was a new vein formation or if we canalized the perforated vein. On our patient, he was negative for arterial workup, and it was reported that the ulcer was attributed to venous insufficiency. He underwent pelvic venous evaluation, and it was reported compression or narrowing of both common iliac veins, and he's scheduled for a procedure, venogram, and intravenous ultrasound in May. This brings us to this last paper from 2020 that they compared treatment for reflux of in superficial and perforator veins and the venous stenosis. So they tried to establish the best algorithm of patients that suffer from this condition. They had 832 patients and divided one group only went to compression, another group only went to truncal ablation, other group was combination of both, and another group was deep vein stenting or combination of these two systems. The results showed that the patients that were only compression had a 75% ulcer healing at 36 months. 51% of truncal showed ulcer healing, and the group of perforators only 68%. Patients that went stenting 77%, but the patients that received ileocaval stenting and ablation of truncal and perforators had a healing rate of 87 to 91%. The ulcer size in this study was associated with venous reflux involving multiple levels, and patients with the largest ulcers had the most advanced multi-level venous disease. The most common site of reflux was superficial and perforator veins, which was consistent with prior reports suggesting that superficial incompetence was high prevalent for ulcerate. And the conclusion was the ablation of truncal and perforator vein reflux, as well as the stenting of deep vein stenosis, all contribute to healing of chronic venous leg ulcers. And that is important to consider ileocaval imaging for a non-healing ulcer after initial ablations. Another patient, at 3 months of the treatment, he reported no improvement of the ulcer. He was sent to another wound care, and it was also a follow-up showing insufficiency of the right GSV. He underwent treatment of varicina for this insufficiency, and the wound care was now being twice a week. So 3 months after the last 3 months, or 6 months in total, he reported improvement of the ulcer. This was the first visit, and 6 months after, we can see improvement on the edges around how it's slowly closing. As we know, he still have to go for the deep vein procedure, but it's showing some type of improvement at 6 months after the treatment. The key takeaway is that intervention of perforator veins is recommended for patients of C5, C6. Perforator plays a big role on recurrence of ulcer. Management for C4, it should be individualized. Superficial venous reflux should be appropriately treated prior to consideration of the intervention of perforator veins. There must be a thorough evaluation of the pelvic venous system. Thermal ablation is the preferred treatment modality, but when ultrasound-guided sclerotherapy is utilized, additional treatment sessions of repeat ablation may be required. These were my references, and thank you so much.
Okay, thank you very much. So if you saw a C2 patient who had reflux with a large incompetent perforator, would you treat that perforator in a C2
C2,
patient?
C2, no.
Right. So the fact of the matter is the majority of the time when you treat the superficial reflux, the perforator incompetence goes away. So it's usually we're talking about 1% of people who have an incompetent perforator that's still present after you eliminate all the other superficial reflux. So um, you talked about foam for perforator disease. I think that's very common in Europe and in South America where they have nationalized healthcare systems. I think you can't control where the foam goes. And we really don't know what the incidence of DVTs is with foam injection. So I'm not a big fan of foam for perforators when we have other modalities. But I think that one of the points that you brought up that needs to be emphasized, there's an initial 25% failure rate right up front, regardless of what modality you use. And then there's a very high recurrence rate of those perforators reopening again.
Mm-hmm.
So perforator disease is very, very frustrating. I think it's very limited when we should consider it. Um, but I'm not, I mean, I do it, of course, but for very, very selective indications. So does anybody have any questions for Madeleine? So again, for the fellows, this was a very thorough review. I would strongly suggest that you review Madeleine's references and read them at your own leisure. Good job, Madeline. This was a very thorough and extensive review. All right,
Thank you
everybody,
so
you have
much.
a great weekend. For those of you going to the American Venus Forum, I'll see you there in Denver. All right, take care, guys. Bye.
Thank you so much.